I'm Dr. Christopher Thompson from Boston, Massachusetts, and I'm honored to speak on the topic of bariatric and metabolic endoscopy at this year's IDEN. I do miss South Korea and hope we can do this in person together again next year. Here are my disclosures. Endoscopic, bariatric, and metabolic therapies, or EBMTs, can be broadly classified into two categories. Gastric devices, including space-occupying devices such as intragastric balloons, gastric remodeling procedures, including suturing and plication, and various outlet obstruction and aspiration therapy type devices. And these are thought to initiate weight loss primarily and then may have secondary effects on comorbidities. The other category are small bowel devices. These include liners that cover the small bowel, duodenal mucosal resurfacing, anastomotic devices, and flow altering devices. And these are thought to have direct metabolic effects with less weight loss. And several of these gastric devices are approved by the FDA and are in current use in the United States, where the small bowel devices are in clinical trials throughout the world. And we'll start with intragastric balloons, or space-occupying devices, and there's several different types. There are gas-filled balloons, fluid-filled balloons, balloons that really are procedureless, adjustable balloons. There are currently two balloons that are FDA approved and commercially available in the United States, a fluid-filled balloon and gas-filled balloon. In general, the indications are class 1 obesity, that's a BMI of 30 to 35 with at least one obesity-related comorbidity, or class 2 obesity with a BMI of 35 to 40. And there's several other balloons that are making their way through the FDA as well, including procedureless balloons that you swallow and pass on their own, and adjustable balloons, as well as some flow altering devices. And these balloons are available internationally in many cases. Moving on to outcomes. Again, we're going to focus mostly on fluid-filled balloons, as that's where the most data is, but we can expect most of the outcomes will be very similar. So this is a meta-analysis of 17 studies looking at a fluid-filled balloon with over 1,600 patients, and the excess weight loss at 12 months was 25.44, and the total weight loss at 12 months was 11.27. And this weight loss was consistent against all BMI categories. Moving on to obesity-related comorbidity resolution. You can see this is another meta-analysis looking at 10 RCTs and 30 observational studies with over 5,600 patients. And there was improvement in HbA1c, a drop of 0.6% across the board, with a 1-point drop in those with abnormal blood glucose at the beginning of the studies. Waist circumference improved, and you saw improvement in fasting blood glucose, hypertension, LFTs, and dyslipidemia as well. The SAE rate here was 1.3%. Again, gastric perforation being a concern, with 5 gastric perforations and 2 deaths, primarily in patients that had prior gastric surgery. So again, that is a contraindication. They also have studied the use of balloons in NASH. And this was a prospective series, 21 patients with early stage liver fibrosis. At 6 months, the total weight loss was 11.7, consistent with prior studies. And here you see the liver-related outcomes. There's a 3-point median decrease in NAS. Fibrosis improved by 1.17 stages. And MRE detected fibrosis improved by 1.5 stages across the cohort. Of note here, percent total body weight loss did not correlate with reduction in NAS or fibrosis. This is a registry of adverse events for balloons. You can see we have a couple of fluid-filled balloons and a gas-filled balloon here. And the SAE rates are fairly similar to what we've been reporting. It was a little higher in this single fluid-filled balloon compared to the gas balloons and the others, but across the board similar for the most part. What about long-term results? This is a very interesting study looking at 500 patients for 5 years. And they excluded patients here at 6 months if they did not meet at least a 20% excess weight loss. And this is about 17% of people, actually. And then they followed them out for 5 years. And only 20% maintained at least 20% excess weight loss at 5 years. So clearly you do have a substantial rate of weight regain after balloon removal, so you have to do something about that. Either start weight loss medications or consider repeat balloon placement. Moving on to gastric remodeling, and this is really where I spent most of my time doing procedures. We patented the concept of intragastric suturing for the treatment of obesity in 2003 at the Brigham. We use it to close fistulas, revise gastric bypass surgeries, and for primary obesity therapy. And there's two ways you can do this. One was really recreating a vertical banded gastroplasty, which was the Roberto-Fogel approach. And then the approach we'd been working on was really trying to recreate a gastric imbrication procedure. This is one of our early studies back in 2008, looking at this approach, which this evolved into ESG. It's a very similar pattern using running sutures along the greater curvature. And we worked together with the Cleveland Clinic group on this, including Stacy Brethauer and Phil Schauer. And we prospectively evaluated 18 patients here, and they had a 27.7% excess weight loss across the board, 30% excess weight loss for those in the lower BMI categories. They had other improvements in waist circumference and blood pressure. However, this was a suction-based suturing device. It wasn't full thickness, and the majority of plications had fallen out at 1 year. And there were no other complications, but the company decided not to pursue this therapy. We then, in 2012, had access to a full thickness suturing device. And here you can see myself and Rob Hawes doing the first-in-man ESG cases, and we performed these in India. And we did one of the cases live at Endocon, actually. And you can see the suturing pattern very similar to that trim procedure which we developed with the other device. Again, suturing down the greater curvature. We broadened this experience to 126 patients for the first-in-man study across several areas, including India, Panama, and the Dominican Republic. The BMI decreased from about 36.2 down to 29.8. And you can see here about a 20% total weight loss. So this was very encouraging and much better than we saw with the partial thickness suturing device. Others, of course, have studied this extensively. This is from Reem Sharaya's group. She studied 91 patients in a prospective series. And you can see here percent total weight loss of nearly 21 at 24 months, SEE rate of 1.1% with a perigastric leak. And what was interesting here is she was the first to really look at these comorbidities. And you see improvement in HbA1c by a point in those patients that were pre-diabetic or diabetic, improvement in blood pressure, triglycerides, and liver tests. She also did another study, 216 patients with 5-year outcomes. And you can see here, baseline BMI was 39. 203 patients had 1-year follow-up. Only 68 patients were eligible for 5-year follow-up. And you can see follow-up rates were quite good at 82% at 5 years. And the weight loss was 15.9%, which is very admirable, especially compared to what we were seeing with balloons. 90% maintained 5% total weight loss, and 61% maintained at least 10% total weight loss. That's fantastic. If you keep in mind that average weight loss with a balloon at 1 year is 11%. So 27% were started on pharmacotherapy after ESG, which is a relatively small portion, and the moderate adverse event rate was again seen at 1.3% of patients with no severe or fatal adverse events. Several endoscopic suturing patterns have been investigated. So far, what we've been talking about has been the triangle or double triangle pattern. It does reduce both the width and length of the stomach, but there are some drawbacks to it regarding tension on particular sutures. Now, what's more commonly being utilized is the U-stitch, where we start on the anterior surface of the stomach, run along the greater curvature, and then on the posterior stomach, we run proximally, and then make our way back up to the anterior surface. And then we'd reinforce that with an interrupted stitch, anterior to posterior, or a short running suture called an I. So we'd alternate UI, UI. And this has become more common. This is a study looking at that new suturing pattern. It's a multi-center international retrospective study that we participated in, as well as 6 other sites in South America. And these other sites had varying experience. So it was interesting to look at differences in outcomes between a very experienced site such as ours and newer sites that are just picking it up. And again, we used a U-stitch, 4 to 6 sutures. And the results are here, 15% total weight loss at 12 months. This was uniform across centers, irrespective of experience. Predictions of success were interesting here, age less than 41, male sex, and higher BMI, which was really the first time we're noticing this. The higher the BMI, the more weight is lost. So quite interesting. And again, that SAE rate is still 1.03% with some perigastric leaks. These did require surgery, but again, lots of centers on the learning curve and very consistent results. This is a 1,000 patient prospective series out of Riyadh, Professor Al-Qahtani, and you can see a baseline BMI here a little lower, 33, and you can see efficacy again, over 15% here at 1 year, and SAE rate 2.1%, including some perigastric fluid collections. Revision rate of 1.3%. What's new here is he was reversing these endoscopically. So it's nice to show even a year later or so you can reverse this procedure. It might be a nice selling point for the technique. And finally, we have a meta-analysis, 8 studies, over 1,700 patients. And you can see the efficacy here, 16.5%, total weight loss at 1 year, and an adverse event rate of 2.2%. Moving on to gastricplication. And this is different than suturing. So instead of mucosa to mucosa, we're plicating serosa to serosa on the backside of the stomach. So we grab tissue with a full thickness tissue grasper. A hollow needle passes through that tissue and deposits a tissue anchor distally here. And the needle is withdrawn. The device is opened and another tissue anchor is deployed on the more proximal side here and secure. So you see this is truly serosa to serosa along the greater curve. We did the first in man work with this many years ago, back 2009, 2008, and we got about a 27% excess weight loss. And then they tripled the size of the device and moved to Europe and did some more studies, and we're getting much higher results, around 60% excess weight loss. And these were uniform across various centers. This is what it looks like a year later, very durable here. This you cannot reverse, unlike with suturing and mucosally based suturing. So this is a randomized sham-controlled trial that was performed in the United States. You can see the 2 arms here. We had over 300 patients in this, randomized 2-to-1 treatment to sham. And unfortunately, this did not meet its endpoints with a total weight loss of nearly 5%. So focusing on the fundus wasn't a great idea. So we've since modified this, and again, this is a report of first man work looking at plicating the body of the stomach instead of the fundus in traditional pose. We work on the body in this distal pose technique, pose 2.0. There's various things you can call this. And with this procedure, we're getting much better results, 15% total weight loss, and we have more people achieving those results as well. So larger studies underway for this technique. Moving on to aspiration therapy. So this is what looks like a peg tube and a long fenestrated drain that runs up into the fundus, and a half hour after eating, someone will lavage the remaining food out of their stomach. So this is a randomized controlled trial and 2-to-1 randomization again, comparing aspiration therapy with lifestyle to just lifestyle therapy alone. And the BMIs here come up to 55, so this was meant for people suffering with higher stages of obesity. So this was successfully placed in 111 of the 113 patients, and most patients went home the same day, well tolerated. Looking at their co-primary endpoints, the first one is percent excess weight loss above the control group, and you can see here in the intensity analysis and the completers, they clearly met that with over 30% excess weight loss compared to a much lower number in the control group. Additionally, there was at least a 50% responder rate based on a 25% excess weight loss cutoff in both the intent to treat analysis and the completers analysis, and much better than the control in purple. The longer you use this device, the more weight you lose, as seen here. It doesn't seem to plateau off, which is encouraging. And you see this out to 4 years in a follow-up study where patients are at nearly 19% total weight loss. In adverse events, the main thing you worry about are persistent fistula, which we're seeing in 12% of people, and 2% required surgery. So very important to be aggressive when you remove tubes that have been in for a longer period of time by ablating that mucosa and clipping or suturing that defect closed to try to minimize the patients that need surgery. Moving on to small bowel type devices. And again, these have a stronger metabolic effect. And First, we have the duodenal jejunal bypass liner, or endo barrier, and you can see here it's trying to replicate a Roux-en-Y gastric bypass. The duodenum is sheltered from seeing any food or any mixing of food and bile as you similarly bypass the duodenum in a Roux-en-Y gastric bypass, and this is thought to down-regulate anti-incretin signaling. Okay, and then you also have food and bile unmixed hitting distal parts of the small bowel more quickly, similar to what you see in the Roux limb, where you augment or upregulate the incretin signaling. So it's thought to have all sorts of positive effects on insulin and glucose homeostasis as well. So here's an example of how the liner is placed. It's very straightforward, over a wire under fluoroscopic guidance, placed into the small bowel. The newer device is quite easy to place. We placed one recently and it seems to go in rather smoothly. You do need fluoroscopy. And this was a meta-analysis looking at HbA1c decrease, and it was reduced by 1.3% across this cohort of patients suffering from obesity and diabetes. So it's important that both those criteria are met. Additionally, the patients had substantial weight loss, 19% total weight loss. So this is a very interesting device. It was associated with hepatic abscess formation in earlier U.S. clinical trials, and now it's back under study in the U.S., and so far we have not had any return of these liver abscesses in the new protocol. Moving on to duodenal mucosal resurfacing. Here we, again, under fluoroscopic guidance, advance a catheter into the small bowel, and this catheter actually has a balloon which expands to push these channels against the small bowel, and then those channels aspirate tissue into them, and little needles are advanced, injecting a cushion of fluid to protect the pancreas and deeper structures. And then that balloon is heated up and it ablates the mucosa. And here you see the little channel the tissue is aspirated into, the needles advanced, and you get your cushion and then ablate that mucosa. So this really does not have any hindgut effects, but it does attempt to ablate this mucosa, kind of simulating a foregut effect or down-regulating anti-incretins. But that's a simplification. It's more complicated than that. I think it's resetting some stem cell activity. So these are results of a single center study, single arm here as well. All patients had type 2 diabetes. There's 44 of them. They did short segment ablations and longer segment ablations. And the baseline patient characteristics are seen here. You can see BMI of nearly 31, so not terribly obese, but with very poorly controlled diabetes, HbA1c of 9.5. And you can see that A1C dropped by 1.2% at 6 months across the full cohort, and it was maintained even after mucosal healing was confirmed on biopsy. So something more durable is happening there. Additionally, if you look at only patients on stable background medications, so not say on sulfonylureas, which have to be adjusted, but maybe on metformin or something like that, they had a greater drop in A1C of 1.8% across that group. Now, the Revita study was interesting, very similar kind of baseline patient characteristics, and also you had a similar drop in HbA1c, but they saw also improvements in liver tests, HOMA-IR, and some other metrics. But what's very interesting here is the MR hepatic fat fraction. There was a 30% lowering of relative fat and a 6% reduction of absolute fat. So maybe we have a solution here for NAFLD and NASH as well. And finally, enteral diversion. This is using magnetic anastomosis. So you can see here it requires 2 endoscopes, one passed from below above the IC valve and one passed from above beyond the ligament of Treitz. And then the magnets are passed from the channel in the endoscope here, and they are coupled under fluoroscopic guidance. So this forms a treatment path where food can quickly go from the proximal bowel to the distal bowel, but also a preserved native path to mitigate against complications as food can go the traditional longer route. And this only really has hindgut effects. We're augmenting incretin signaling, but we're not really doing anything to that proximal small bowel. These are results of a pilot study looking at the dual path enteral bypass. 10 patients, 3 were pre-diabetic, 4 diabetic, had laparoscopic supervision with this as well. And you can see diabetic patients, the A1C dropped from 7.8 down to 6, and the pre-diabetics dropped from about 6.1 down to 5.2-ish. And there was also about a 14% total weight loss here. And this is at 3 years, so good durable outcomes. Additionally, we mentioned NAFLD and NASH a few times. This is a meta-analysis from our group looking at the effect of all EBMTs across the board on liver disease. And we found 18 studies that looked at this, including balloons and suturing and whatnot. And there were 863 patients total. And across all these different technologies, they got about a 14.5% total weight loss at the 6-month mark that they were looking at. And primary outcome here in this meta-analysis was liver fibrosis. We found 4 studies with 162 patients looking at this. And fibrosis was reduced by a standard mean difference of 0.7 across these studies. And secondary outcomes such as ALT, hepatic steatosis, and histologic NAFLD activity score all improved statistically significant as well. And the grade methodology looking at this did show that the quality of evidence was low to very low for these studies. So summing it all up here, we have a full spectrum of therapy with bariatric endoscopy, with balloons giving about a 10% total weight loss at a year, ESG and POSE getting 15 to 20%, aspiration therapy in that 15 to 20% or so as well, fitting nicely under surgery and above medications and across a broad group of patients. In conclusion, EBMTs are proving to be effective and have an increasingly important role in the treatment of obesity. EBMTs also may hold promise in the treatment of type 2 diabetes and across the spectrum of fatty liver disease. And combination therapies and personalized treatment programs, I believe, are now the keys to future success. Thank you for your attention.